My name is Matt. I am a 11-year papillary thyroid cancer survivor from Seattle, Washington. And this morning's session is what is radiation oncology and how is it used in our thyroid cancer journey? It is my pleasure to introduce Dr. Ryan Lanning. Dr. Lanning is a radiation oncologist at UC Health in Denver, Colorado. He graduated from Harvard Medical School in 2011 and completed his residency at Memorial Sloan Kettering Cancer Center. He specializes in head and neck cancer, melanoma, radiation therapy, sarcoma, and skin cancer. And please raise your hand in the room if you have a question, and we'll bring a microphone to you. And to the folks on Zoom, if you want to type your question in the Q&A section, that'd be helpful. Or if you'd like to speak, raise your hand, and we will call on you to speak your question. And with that, I present Dr. Lanning.
Thanks so much for the introduction, and thanks for the invite. It's really an honor to talk to survivors and people who have been through many different treatments. And I don't know how many of you have been through, well, I know some of you have been through what I do, but I don't know how many others have here or online. So hopefully I'm going to demystify some things and sort of talk about when we might use radiation, in this particular case, external beam radiation in thyroid cancer. And I have no disclosures. A little bit about me. You already heard the sort of CV, but I'm originally from San Diego, did schooling out on the East Coast, and then moved here to Colorado about 7 years ago. This is my family, my wife, Gina, son, Sean, he's 7. He told me to do a good job today, so I will try. And my wife told me not to talk too fast. And so some topics that we'll talk about today is sort of what is radiation? What is external beam radiation? When do we use it in thyroid cancer? What are side effects to be expected? And then what are some future directions with radiation in thyroid cancer? And I have caveats here, and I'll have a caveat slide in every section, I think. But basically, surgery is the primary treatment for thyroid cancer. And also, there's no randomized trials of radiation therapy whatsoever. There's actually not really any of radioactive iodine as well. It's just, it works very well too. And that the treatment of thyroid cancer, it's multidisciplinary. So when I see someone, it's usually as part of a multidisciplinary clinic or a tumor board or team where we are all discussing the different potential treatment options as a group and deciding if we want to proceed with radiation as one of the tools. And so I'd like to unpack this sort of black box for you of what radiation is, particularly external beam radiation. And so basically it's electromagnetic energy, it's light. And in particular, what we use to treat cancer overall are X-rays or gamma rays. So this is radiation you can't see with your eyes, but they're photons. And how they really work is that in the therapeutic range is that they are ionizing. And what that means is there's an atom here on the screen. And so this radiation comes in as a lightning bolt. That is our radiation symbol from PowerPoint. It's really the only one that works. So it comes into an atom, hits an atom, and it ejects an electron. Think of an electron as like a little baseball, and the electron is actually what goes off and does its work. And this really only happens at high energies. So the X-rays you get when you get a CT scan or a chest X-ray, they're not doing that. They interact with the body differently. And really, how does this radiation, this ionizing radiation, interact with the body? It actually interacts with the DNA. So these photons, these X-rays pass pretty much all the way through your body. Most of them don't interact with you at all. But what we want them to interact with is the DNA in the cancer cell and the thyroid cancer cell. And how they do that is either directly by hitting the DNA itself, breaking up strands on the DNA. You can see the double helix there on the screen and the figure. And then at the doses we commonly use to treat most cancers, they interact with the water around in the cell, and they create free radicals. And these free radicals diffuse over nanometers, which is very, very small distance, and then damage the DNA. And so that's really in the indirect. And then when you get external radiation, like sort of radioactive iodide, everyone knows they measure that in millicuries. That's the activity. It's sort of the disintegrations of the radioactive iodine. When we use external radiation, we use something called the gray, which is the dose. It's basically the energy absorbed in the body per mass. And some of the numbers you might hear is no one walks around and said, I got 1 gray or 2 gray. You might say, I got 60 gray of radiation or 30 gray. And many times we convert that to centigrade, which is there's 100 centigrade and 1 gray, or the older term, which a lot of my dental colleagues use, or rads, which I think is better. It's fun to say rads, and that's an equivalent to a centigrade. And what are the goals of radiation? This is my Goldilocks plot. So, you don't want it too cold, you don't want it too hot, you want it just right. And so our goal is always to maximize the tumor control, but not cause a lot of harm to the individual who's getting the radiation. So you want to increase the dose of radiation to the tumor, but decrease the dose to normal tissue. And there's many different ways that we try to do that or have been studied. And then there's different flavors of radiation. So I was sort of talking about X-rays, which are photons like light. But there's other forms of radiation that we use sometimes in thyroid cancer that you may read about. Electrons, this is mainly for treating superficial stuff. I mentioned electrons being knocked out of atoms. We can actually make electrons and target them at tissue. Usually this is for stuff in the skin. You can think of them like little baseballs, hit the tissue, slow down and stop. There's brachytherapy. It's literally Greek for close radiation. We don't really use this at all in thyroid cancer, but prostate cancer, things like that. So this is, you can insert needles and then directly apply radiation locally, or radioactive seeds, which actually radioactive iodine seeds we use for prostate cancer. Protons is something that people might read a lot about, particularly anything in the head and neck region. So protons, they are charged particles. They're actually what's in the nuclei of atoms. Those machines cost $30 to $100 million to build and install, so they are not cheap. And there's about 50 centers around the US now that have them. And the big question is, with these protons, do they help that sort of not too hot, not too cold kind of thing? Because there's some physical properties of them where they basically penetrate into tissue, and where they stop is where they deliver all the dose. And so the thinking is they might decrease side effects. And there's actually some randomized trials going on for head and neck cancers, as well as lung and many other sites, to try to determine if they will be more beneficial than other type. They cost a lot more to do those treatments too, which is one of the things. And then some that we no longer use are these neutrons and heavy charge particles, certainly not in any sort of thyroid cancer. And then this is just a plot, which is going to be hard to decipher. But the red graphs is actually the protons, just so that everyone knows why everyone gets excited about protons. They go down and they have this thing called the Bragg peak. It's that peak at the right side of that figure you can see on the screen there. And the thing that the general public doesn't know about protons is that how deep they go is how fast they're moving, their momentum. But if you just have one particle, one momentum, then you only go to one depth, but nothing we treat is at one depth only, or one point. So you have to use these protons of different energies, different momentums to travel into tissue. And that's really what this graph with all these little hills, on the screen here, sort of building up, and actually builds up your radiation dose at shallower tissues. So it's not like it's a total end all be all of treatment. And we're finding that now in our clinical trials. So this one I do want to spend some time on, sort of the external radiation beam techniques, because to break it down to different things, because there's different number of treatments we can do. We call them different things based on the number of treatments, the different doses. I was having this discussion earlier outside about what we call different things. So standard treatments, what we call conventionally fractionated radiation. This is usually 25 or more treatments. Daily radiation, Monday through Friday kind of thing, kind of low dose each treatment. So this is typically the standard way we might give radiation external beam to someone with thyroid cancer after surgery or things like that. It might be 6 weeks after surgery, or 7 weeks if there's no surgery. And then we use different techniques. There's 3D radiation therapy. That's an old way of doing things. This intensity modulated radiation therapy, it's a bit fancier, allows more conformal treatment. And then this arc therapy, which is even faster than the IMRT, and does even more conformal. And then on the other far end of this is the stereotactic radiosurgery. And so this is single treatment. This is often used for things in the brain. And so rarely we do see thyroid cancer in the brain, and this is typically the treatment of choice for doing that. We pretty much never do whole brain radiation anymore. So if anyone ever recommends that to you, ask for a second opinion. because it's really not something we do. There's a lot of side effects. And then a little bit above this is anything from 2 to 5 treatments we call stereotactic body radiation therapy, or if you like Star Wars, there's Saber. That's another one, stereotactic ablative radiation therapy. And this is much higher dose, but shorter number of treatments, usually done every other day or even less frequently, with the goal of ablating the tumor. And not too often used in primary thyroid cancer, though I'm going to show some data that we have here at the University of Colorado doing it, but a lot of time in metastatic disease, particularly oligometastatic disease, which is 5 or fewer lesions. Then in between there, there's this whole sort of wild west of what we call hypofractionated radiation, which just means it's more than 5, less than sort of 25. So this is sort of, the dose is moderately higher than it is when you do it for 6 or 7 weeks. But it's a longer course treatment. It's usually daily as well. And so this picture here is the way we used to do radiation. It used to be you'd do an X-ray on the treatment machine, and then you literally take a wax marker or pencil and draw out your fields. Took like 15 minutes, done. Wasn't a lot there. And then they invented the CT scanner. And so now you were able to do a CT scan. So what you see here on these figures is a CT scan of someone's head. The white stuff is bone. That's the mandible on the top of the figure. And the vertebrae is behind there. This is sort of a little bit above the thyroid level of the thyroid. And what I'm showing here is on the left side figure, that's the old 3D radiation. And those colored lines, that sort of heat map, is the radiation dose. So you can see it kind of just goes through the body without really any care for what's around. You're possibly treating what you want to treat, but you're also hitting a lot of other things, salivary glands, the mouth, the throat, the voice box in this case. And so this intensity modulated radiation therapy was basically a physicist in the 1990s at Memorial Sloan Kettering Cancer Center actually said, well, instead of doing that, what if we used radiation from multiple angles? So a lower dose each beam, but maybe 8 or 9 beams of radiation targeting the area. And this made it more conformal. So you could really shape around an area you wanted to treat and avoid normal tissues. It allowed you to give some areas more dose than other areas, what we call dose painting. The issue with this is it takes more time to plan. You can no longer just draw on the X-ray and you're done. This takes usually around 7 to 10 days to plan this out because there's a lot of quality assurance checks that go into it as well. And then this is our workhorse for giving X-rays, which some of you may have seen before, or I know some of you have. And so this is what makes the X-rays. It also can make electrons that I mentioned earlier. And what you see here is, I think, some key points that I want to describe here is that this is not like a CT scanner or an MRI. You don't go inside of anything for getting external beam radiation. That black table that you see sitting there, we call it a couch, which is kind of an unfair term because it's not remotely comfortable like a couch. But that's sort of where the individual lays down who'll be getting radiation. Then we also have some sort of fixation device because the radiation needs to be very precise and reproducible. If you're treating someone for 6 weeks, or even if you're treating for someone for 5 or 1 treatment, you want even more precision there if it's a higher dose. And so for treating the thyroid, we often have customized masks, which have been getting better over the years. They used to cover everything from the top of the head to the shoulders, not open. The plastics and technology have gotten better. Now they're completely open in the face, which certainly make it more tolerable, but you're literally getting tacked down to that couch. And then, if you're treating another part of the body, you would usually immobilize that, say an arm or something else, keep that in the same position every day. And then on this machine at the top, that round part, that's where the radiation comes out. And that's where these little leaves are that shape the radiation. And on the sides, there's these things that fold in that actually image. So most of the radiation we do today is image guided radiation therapy, which means there's literally a low dose CT scan that's done on the machine compared to the CT scan that you saw earlier that we sort of use for planning. And so there's a lot of precision. And then actually the couch now, pretty much every machine modern is robotically controlled and has 6 degrees of freedom, which means you can do pitch, roll, yaw, you name it, up, down, and really line, and it has sub-millimeter resolution. So you can really get something lined up very well. So that's all part of, decreasing, increasing the therapeutic ratio by, increasing our way we're able to design and deliver the radiation. So now, when do we use this external beam radiation in thyroid cancer? Because the majority of people never, fortunately, have to see someone like me. So again, my caveats, the key thing here is there's no randomized trials of external beam radiation therapy, and surgery is the treatment of choice. And then certainly there's some thyroid cancers we do use radiation almost every time. So certainly the more common differentiated medullary, tall cell variant, things like that, we won't necessarily ever use external beam radiation. They're often using radioactive iodine, certainly for differentiated thyroid cancers like papillary. But dedifferentiated thyroid cancer, or certainly anaplastic, we do use radiation pretty much in almost everyone, either up front or at some point in their care. And I'll talk a little bit more about those. And then also depends on the disease state. In the primary setting, someone's initially diagnosed, external beam radiation is often not used. I would say 99.9% of the time. It's often recurrent when someone's had multiple prior surgeries, and then surgery gets more challenging, more difficult, or higher risk. That's when we use it, or in the metastatic setting. So when it spreads someplace else in the body. And then there's really now in cancer in general is being defined two different states of metastatic disease, what we call oligometastatic, which is defined anywhere from 3 to 5, and polymetastatic, which would be more than that. And the key difference here is that there's an understanding now that there's a possibility of taking people with oligometastatic cancers, and I'm speaking globally, cancers in general, and making it a chronic disease. And then actually with radiation, there's one randomized trial in the US that took all comers. I do not believe there were any thyroid cancers on it, mostly breast, lung, prostate. And they said, hey, if you have 5 or fewer, we'll radiate you with high dose ablative, that 5 treatment regimen, or you can get standard of care systemic therapy. And there was 2.5 times overall survival benefit with the radiation over the standard of care. And then the UK did a prospective trial where they actually have a whole group that does this SABR stuff in their national healthcare system, and said if you have 3 or fewer, we call metachronous, which means like usually a year later from your original diagnosis, metastatic disease, then they did a trial and showed actually great overall survival benefit. And so that's standard of care in the UK now. If you have 3 or fewer metastatic sites, they do this ablative radiation. And so it's stuff I use to get it approved here in the US. So for differentiated thyroid cancer, the standard treatment, someone gets a thyroid ultrasound, a biopsy to confirm, and then a thyroidectomy. You get surgery. You do TSA thyroid suppression, and then typically radioactive iodine, either treat any remnant thyroid tissue that's left or any sort of remnant thyroid cancer. And then the question is, when do you use external beam radiation, if at all, in this setting? And so I'm trying not to show too many slides here of clinical trials, but most of the data we have is retrospective, meaning it's some big institution went back and looked over many years at their data. And so this was one of the largest from Princess Margaret Hospital, which is in Toronto. And if you haven't heard of it, it's the largest cancer hospital in Canada. It's sort of the MD Anderson of Canada. And so they published, in the early 2000s, over 700 individuals they had treated with differentiated thyroid cancer, mostly papillary. And these individuals had had surgery and then radioactive iodine. And then, within 3 months after that, got external beam radiation. This was usually 6 weeks of therapy. And they tried to look at who benefited from this, if at all. And sort of highlighted here, they found a subgroup where it's, over 60, T4 disease. So this is typically extrathyroidal extension, meaning it's grown out of the thyroid, invading into surrounding tissues, and nothing left behind, meaning surgery took everything out. And at 10 years, they actually saw that radiation, had a, 80% to 65%, cancer specific survival. So people were living longer that had the radiation and not succumbing to disease, and also a better local recurrence-free survival, meaning it wasn't coming back in the thyroid bed or neck. And so that figure over there shows the difference. The dotted line is the with radiation. The darker line is not. And so the Germans, not to be outdone, said, hey, we're going to do a prospective, tried to randomize multi-center study on differentiated thyroid cancer to see if adding post-operative radiation after radioactive iodine would be any benefit. And again, they did select the more advanced tumors that had extrathyroidal extension, had nodes that were positive, or had positive surgical margins. And they gave the radiation a few months after the radioactive iodine. Um, they tried to recruit almost 400 people. Only 26 of them got radiation. So it's hard to know in this study, but they did publish it. So it's data we have. And I think, the thing here is that they thought that the group that wasn't going to get radiation was going to have an almost 20% recurrence rate. They were 3%. So they did very well. And basically what you see here is the top straight line. Those are the 26 folks that got radiation, didn't have any recurrence whatsoever. And then the sort of dash line below that has a lot more individuals on it. That's just the radioactive iodine alone. 3% of them had recurrences. And so their conclusion was don't do external radiation in differentiated papillary thyroid cancer. Now I talked about these more fancier radiation techniques like IMRT or the arc therapy, because a lot of that stuff I just showed you from Princess Margaret, that's going to be using older techniques mostly. And so there was a Korean study where they actually did a prospective and again tried to randomize, looking at the same sort of more advanced papillary thyroid cancer groups doing radioactive iodine alone versus external beam radiation, then using fancier radiation. And so you can see these curves. One is for local recurrence-free survival, and one's for overall recurrence-free survival, meaning like anything coming back anywhere at any time. And there's a difference. The radiation arm almost has the radiation arm had, external radiation arm had no local recurrences. And it had, there was one or two that did recur elsewhere in the body. And so they saw a significant difference in those groups there. But then the most important thing is how long someone lives. At 4 years, everyone was still alive no matter what treatment they got. So again, this doesn't really justify doing any radiation for differentiated. Now, what about more aggressive variants? So de-differentiated or poorly differentiated thyroid cancer. These are the ones that can be more rapidly growing, can act more aggressively. And so sometimes we escalate therapy. So adding in chemotherapy. So this was a study done out of Memorial Sloan Kettering Cancer Center in poorly differentiated or de-differentiated thyroid cancer, phase 2, randomized, adding in a chemotherapy called doxorubicin, also known as the red devil. Some people have heard of that because of its infusion reaction it can have. But it does have sensitivity in thyroid cancer. And one of the interesting things about, the more aggressive variants of thyroid cancer is that they typically grow rapidly, which also means they respond more rapidly to cytotoxic therapies such as chemotherapy or radiation. And so this basically gave it, and they saw when you gave chemotherapy with the radiation, basically no one recurred in the neck. But again, it didn't change survival at all. And it had a lot of toxicity. A lot of people got feeding tubes during this treatment because of esophageal toxicity. And so this is tough, but some of the, half these patients couldn't even get surgery. So, this is an alternative for that. And then, the last one is anaplastic thyroid cancer. So this is the most aggressive. We actually, and I think Dr. Haugen at the University of Colorado is one of the pioneers in this, developing sort of a rapid response team for anaplastic thyroid cancer, because this is something where, unfortunately, I've seen individuals who a week ago were climbing a 14er, which in Colorado, that means a mountain over 14,000 feet. And then the next week they can't breathe. And they're getting a tracheostomy and things like that. So we actually have this group where there's an email and a page that goes out to radiation oncologists like myself, surgeons, which include the endocrine, the head and neck surgeon, the endocrinologists, the whole team, the palliative care team, everyone, so that we're all aware of someone coming in, and the pathologists, because we want them to do this BRAF testing, which is a targetable mutation in anaplastic, found in almost 2/3. And typically, if you can take it out, we try to take it out as soon as possible. So that's, and then often most of those individuals get radiation afterwards, which can be for 6 weeks or shorter. Sometimes we're moving into the more hypofractionated realm in this area, which radiation has been shown to, prolong life when you do it after surgery. And then so our protocol is typically surgery if you can, and then often chemo radiation afterwards, with those agents there, which are typically given on a weekly basis, try to enhance the efficacy of the radiation. Um, and showing a radiation plan there on the right side, where that, again, that heat map is showing. In this case, unlike a papillary, we might just treat the thyroid bed only. You're often treating the lymph nodes in the neck to make sure we're getting all of those as well. If someone's not resectable, but they have a BRAF mutation, we're often putting them on BRAF MEK inhibitors that really have shown remarkable responses in some cases. And if they're unresectable, often chemoradiation. And there's a lot of data that's coming out recently showing some new therapies, including immunotherapy. And then something we're doing at the University of Colorado that really hasn't been done before for differentiated thyroid cancer, that's recurrent or recurrent and metastatic, is doing higher dose, the stereotactic body radiation therapy to the primary site. So this would be in the thyroid bed or the lymph nodes in the neck. So we've done this for about 7 years now, basically since I've come here. Now we almost have 20, but showing here you hear 14 individuals that I had recurrence in this. And when I talk about recurrence, this is typically unresectable. There's often people have had, I think, a median of 3 prior surgeries. They've had radioactive iodine, I think, at least twice, most of them. So this is heavily pre-treated. I've had multiple people with invasion of the trachea, invasion of the esophagus. So we get MRIs, have them see my colleagues in ENT to get scopes. And then we do these 5 treatments, often twice a week for 2.5 weeks. And right now we've had 1 recurrence at a median follow-up of 4 years, which means everyone's been followed for at least 4 years and only 1 person has recurred in the radiation field. The problem we found is that we were doing just localizing to the area where there was something disease, and now we're getting recurrences out of the radiation field. And so we've modified our protocol now where we're actually doing sort of what we call elective treatment too. I talked about dose painting with radiation. So we can give areas where there's disease, higher dose, and areas where there could be microscopic disease, lower dose. And now those individuals are not having failures nearby. And so this is something that's currently not in the NCCN guidelines. So we're working to hopefully help get it in there, because this is, as many of you know, for papillary thyroid cancer, differentiated can be a chronic problem. We call it an indolent sort of cancer, meaning slow. Someone lives with it and doesn't succumb to it. And so many times if someone has lung nodules, it could be from the thyroid cancer, to subject them to 6 weeks or 7 weeks of radiation seems unreasonable. And so this is something we're trying to do to sort of change the paradigm and how we're treating in this setting. So just to summarize, because I think I just showed a bunch of slides that said you should never ever see me for most part for radiation, but we do. I mean, I do treat people with primary thyroid cancer after surgery. And so, when is that? Most commonly, it's someone that's had multiple prior surgeries, and we're worried about what we call the recurrent laryngeal nerve, which can affect voice or things like that. It's usually in people over the age of 60 that might have poorly differentiated thyroid cancer that we'll be treating. When it's been such an extensive surgery and there's likely positive margins around, and maybe the individual's thyroglobulin, it was low to start with. Some people walk in with a thyroglobulin of 300, 1,000. Someone walks in with one of 20 but has a big tumor. You worry about, can you use that as a marker for following? And so in those cases, we might use radiation. If the surgeon comes to me and says, hey, I put clips in there so you know where to radiate, then I know they want me to radiate because they're concerned about something and they were the ones that were in there. And then certainly anaplastic thyroid cancer is one where we pretty much always do. And then I won't spend too much time on this, but in the metastatic setting, when it's spread distantly, where do we use it? That oligometastatic versus polymetastatic. Thyroid cancer can go to the lungs, so we treat lung spots, bone spots, spine spots. I have seen skin and brain, and often, many times, these are done with that ablative radiation, so the 1 to 5 treatments, which I would put the control rates in excess of 90% at 2 years in those settings, using those kind of treatment regimens. And then side effects of radiation. And if someone has a question, please ask away. I don't know if we have any. Okay. before I talk about side effects here.
Two questions. The commonly used term cyberknife, is that the same as your stereo example?
So CyberKnife's a trademarked brand name.
Oh.
So CyberKnife is basically it's the stereotactic body radiation therapy. It's not done with the linear accelerator that I showed you. It's done with it's considered a robot. It's a machine that sort of rotates around you on a big arm, but there's no necessarily advantage of that over the Linac-based radiosurgery. The Initially there was, because they were able to do that in a mask and it was more precise, but since technology just constantly gets better, we're able to do those kind of treatments with CyberKnife style treatments on the regular linear accelerator machines that most centers have. Now there are different versions of linear accelerators. There's some that have higher resolution and a lot more precise, and so those are the ones we do those kind of treatments on.
Oh, when you said the surgeon left in clips for
Yes.
you to note, what is that about?
I'm gonna get myself in trouble. So anytime someone does surgery, they're cutting things out, they're cutting vessels, and they will often clip those vessels. And many of you who have had a thyroidectomy or something are getting ultrasounds of the neck. No radiation involved, pretty simple, nice warm, the stuff they put on your neck, the gel. But there's often clips that are left in, which are a little metallic. I'm not sure what material they're made out of, but they often use them just to like, oh, it's bleeding here, we'll close off this vessel, clip that in there. But if a surgeon's worried about a margin, they'll actually put some extra clips there. That way, when I go in later, I mean, they're really thinking about you guys when they're doing that, because they really want me to focus on where they're most concerned. And so, yeah, I've treated, part of the thyroid bed or things like that when there's only one part they're concerned about. So those are the clips. Almost every surgeon uses them, but.
Question on Zoom. Patient, if you gave a patient 332 milligrays per centimeter for PET CT, do you have any idea on what the whole body millisievert exposure might be?
I feel like I'm
Very
at my
specific.
oral boards now. It's certainly below the 50 per year that you're allowed. I don't know if I'm going to be able to do that over. Yeah. So what's a PET scan? A lot of you may not know that. It's not one that's for your dog or cat. So I want to clarify that, because I've been asked that before. Someone said, I'm not going to go get a scan for a dog. So a PET scan is positron emission tomography. It's kind of, we do SPECT scans with the radioactive iodine. Those iodine scans are considered that, but these positron emission tomography use a special radioactive isotope. Usually it's glucose, that's been modified with a fluorine isotope F18 that emits these positrons. And so you inject that into someone, and if they have cancer, infection, or inflammation, that F18 glucose goes to those there, the sugar does. And so the individual is radioactive after that injection. It's got a half-life of 117 minutes. And so in about a day, they're no longer, but I don't use the bathrooms near the PET scanner, and neither should you, unless you were there for a PET scan. But in thyroid cancer, papillary or differentiated usually does not light up on a PET scan. So I'm not going to directly answer that question, because I don't know the answer off the top of my head, except that it's low. The PET scans we often will use in the anaplastic or the dedifferentiated, or let's say someone no longer is having an uptake on an iodine scan, then that's when we think that a PET scan might be a better tool for following that.
If you're getting a PET CT, do you suggest keeping your hands up or down?
Oh my, that's a good question. My next caveat is that I'm a radiation oncologist, not a radiologist. So I'm going to do my best with these answers, which means I didn't train in that. But this one I actually do know the answer to, and it really depends upon what you're imaging. So the arms get in the way of the positrons that are leaving your body. And they do try to correct for that when they're doing the scans and the post-processing. And so, as someone that treats a lot of head and neck cancers, what I can tell you is it's beneficial to me if your arms are down, to do a focus scan of the head and neck, and then to image the rest of the body, because you might be concerned about the lungs or liver and you don't want the hands away, then arms up. So actually what we've developed, and many centers do use this, is we do 2 scans. And so we do one whole body, or usually it's from vertex to mid thigh, with the arms up. So that's getting everything. And then we'll do a dedicated head and neck CT scan with the PET scan. So you get a higher resolution PET scan. So it really depends upon what your doctor's looking at or looking for.
Patient with, trying to be not too specific, persistent poorly differentiated oncocytic carcinoma in the right neck, only encasing the right vagus nerve. 60 gray by IMRT didn't quite eliminate.
Yeah.
Do you think, what are your ideas on re-irradiation or SBRT?
How long ago, I guess, would be my first question. 60 gray is what we consider an adjuvant dose. That means post-operative. So it treats microscopic disease, meaning you shouldn't see really much on a scan when you're doing the planning. Otherwise, we typically give more towards 70 gray or 7 weeks, 35 treatments of radiation. That can be a difference. Again, that's that whole Goldilocks plot with like just getting just right. Now, re-irradiation at the university, we do unfortunately do a lot of that as one of the only NCI designated cancer centers in 800 miles. So we do see a lot. So yes, you can re-irradiate in the neck. That's the long and short of it. And typically we want it to be at least 6 months out from the original radiation. And often I do use SBRT when I re-irradiate. My thinking there is there's some benefits and toxicity over the short and the long term. But also if the initial course of conventionally fractionated radiation didn't work, then try something different. With re-irradiation, the key points there are, if it's resectable, resect it first. If it's not resectable, then you have to give a little bit more dose of radiation. And you treat only what you have to. So you don't electively treat. I had used that term earlier about electively treating lymph node basins or things like that. But if you're re-irradiating, you just treat what you need to treat. So.
Does radiation oncology include MRI, CT, ultrasounds, REI? Could you explain the difference between a radiologist,
yes,
interventional radiologist, and a radiologist or radiation oncologist?
Should have started with that, because it does get confusing. So, the radiologist is an individual that reads scans like CT scans, MRIs, ultrasounds, you name it. The interventional radiologist is a radiologist that did an additional fellowship so that they can interact with people and poke them. Usually putting in lines, biopsies, that kind of things, often guided by some of those CT scans, things like that. A radiation oncologist, just to make things really confusing, is we are boarded by the American Board of Radiology, but we do an entirely different residency and things like that. So radiologists, they do an internship. What does that mean? That means they go and they might do internal medicine for a year, and then they go into a radiology residency for about 3 years. And then they graduate and they might go into a fellowship, become an interventionalist or things like that, or do a fellowship in neuroradiology for doing the neuroimaging, things like that. A radiation oncologist does an internship. So I did internal medicine for a year and then in the hospital. And then you go off to 4 years of residency. And as a radiation oncologist, we actually learn about every type of cancer because radiation is used in almost everything. Now, do I know how to look at and evaluate MRIs, PET scans, CT scans, all that kind of stuff? Yes. I have formal training where I do reads on those and get paid for doing? No. And so that's the big difference there. So we are considered oncologists. So we have oncology training versus a radiologist is more of someone that sort of looks at a scan and does what we call a differential diagnosis. They sort of figure out what's going on, which could be a cancer or many different, most likely something else. I don't know. Did that answer the question? I think so. I mean, even we make jokes about it that people's families, I think my residents just did a little skit where it was like one of them went home and like their mom was like, "Oh, so you're a radiologist and how's reading films," or something like that. So it's a common thing where people don't exactly know what we do.
Follicular variant papillary.
Mhm.
Some lymph nodes involved, positive margin on the tumor, no genetic testing was done, 30-year-old male. Anything you would advise should be done before REI?
Well, they'll do an iodide scan just to check that. And then, yeah, I think RI is very appropriate there. And I should actually say radiation oncologists do give radioactive iodide in some centers, often more community hospitals. At larger university hospitals, there are nuclear medicine radiologists. They are not oncologists, but they're the people that read the PET scans or SPECT scans or all those kind of things that do the injections, and they often do the radioactive iodine. So, but radiation oncologists can do radioactive iodine, and we do get boarded in it and everything.
Would external beam radiation, do you think it'd be beneficial for a patient with PT3B with extrathyroidal extension only to the strap muscles? One lymph node was involved with clean margins otherwise?
I wouldn't use it in that case. The reason is if it's negative margins, and it wasn't, if it was just strap muscle invasion, not tracheal or further out, and only one lymph node, particularly if that lymph node was in the central neck, I would just do the radioactive iodine follow up.
One more. Going back to the hands up and hands down protocol for CT. If you do the PET CT with hands up and down protocol, does a positioning CT need to be done both before hands down and then another before hands up?
Yeah, so that's a great question because again, CT scans do give you radiation. I mean, radiation exposure. So it's not like we want to give people more radiation. So yes, you would do a whole body or most body scan with the hands up. And then if the hands down, that would usually be just imaging the neck, the head and neck. So it's a more localized scan.
Any other questions in the crowd?
No, we got one. And I should say that a transcontinental flight is equivalent to about 4 of them is equivalent to a chest X-ray in radiation exposure. Just
So I've heard this from more than one source, but that radiologists, which you're not in that field,
yes,
you're
thank you.
right, tend to be alarmist. And I'm using that word, right? Like they overemphasize perhaps what they're seeing, sort of covering the bases, and we all react to that as patients. Like
Yeah.
it's worst case scenario that may end up being nothing. Is that kind of what, I mean, is that what their training is, really to cover the whole gamut, and we should take what they say and their impressions with a grain of salt until they explore further?
Yeah, this is a great question. As someone that takes care of individuals that get their scans, and as of 2 or 3 years ago, when according to Medicare rules, all lab reports, imaging reports needed to be released immediately to the individual, who then now with all the online access, which is great. I mean, I love communicating with people I take care of online and being but reading those reports right away, which is unfortunately in medical jargon, which sometimes I'm Googling what the heck they're talking about. But yeah, radiologists are trained to do what we call a differential diagnosis, which is what medicine in general. Someone walks through with a cough into your primary care office, you're gonna say, oh, is it a cold, allergy, name it, postnasal drip. And so when a radiologist is looking, they often don't have the context. The good ones do. Usually if they're at a big university center, they often are specialized. So if someone like just looks at the head and neck, or someone just looks at the ultrasounds of the thyroid, and they read their breast is a big one. They've shown big benefits to like having just mammographers who that's all they do. It really makes a difference in outcomes. And but the general radiologist or even the specialized one, when they look at a scan, If they see something, they're going to say something, and they're going to say what it could be. Now, some centers, and we actually been trying to move toward this here, but where I trained, they actually would say this maybe, suppose, like they would actually have this word to describe what they're looking at, particularly when it had to do with a cancer patient. And then there'd be this little thing down at the bottom that would basically said, if it says this, it's like 50% or less. If it says this, it's like 50 to 75%, it's 75 to 95%. So they actually would have something that sort of helped. But yeah, I mean, it's not that I mean, they sort of are covering themselves, but they're also trying to give who's ever reading it. But again, good ones. Oh, this person had surgery, so what I'm looking at is more likely surgical changes than recurrent thyroid cancer or something like that. So often they will go look at the chart, and most of the time when I go in to chat with someone, they have our medical record open as well as their imaging system open to look at things. Okay. Sure. Let's jump there and then we'll have more time for questions maybe. Okay. So side effects, another caveat slide. So the side effects of radiation depend upon what and where you're treating. So if I'm treating someone's arm, they're going to be different than I'm treating someone's neck. If you add in additional treatment, surgery, systemic therapy, you're going to have increased side effects. They contribute. And again, the care of thyroid cancer is multidisciplinary. In this case, I'm not even talking about doctors. So when I treat someone with thyroid cancer, let's say post-operatively, I get a speech and swallowing therapist involved. I get a nutritionist involved. We get lymphedema therapists, for neck massage, things like that. So those are like, I insist upon people getting those because it just really helps with recovery and things like that. And so this is going to be a big slide of like thyroid cancer side effects from treating the neck. And so I'll go through some of these, but the short and long-term side effects of radiation. The short-term side effects sometimes turn into long-term side effects. And again, this is really where it depends upon where you're treating in the neck, because I will have individuals with thyroid cancer who have done their homework and they've gone and read about what it's like to get radiated to the head and neck. And then they come in with a lot of understandable concerns about what they might be going through. But most of the time when I'm treating someone, particularly with a differentiated thyroid cancer that might be recurrent, I'm just treating their, and online, I guess you can see that I'm just treating their neck by their Adam's apple. I'm not going up into the mouth or the throat or anything like that. And so no one's losing taste. No one's really getting a dry mouth from that. And so, all those kind of side effects that can be really impact things. But anyone that gets radiation is going to get tired, call that fatigue. Treating near the thyroid, the esophagus sits right back there. So we get something called esophagitis, which means we're upsetting the esophagus. You get throat pain, you get some difficulty swallowing. Hoarseness, you can see that just from inflammation, swelling. We're very good at avoiding the voice box. And someone might ask, well, my surgeon's always worried about this nerve and things like that. The radiation, the risk of injuring the recurrent laryngeal nerve and causing permanent hoarseness is incredibly small. You need a lot of radiation dose to do that. But, if you're just treating the thyroid bed, dry mouth and taste changes are very infrequent. We do see neck swelling. We call that lymphedema, and there's good therapy for that. Stiffness, particularly if you've had surgery. Dry mouth, if we had to treat up there more comprehensively, but I tried to break these up. So esophagitis, most common. This is usually happens, we say 3 to 4 weeks into treatment. Sometimes people are later on because we're getting better and better at avoiding the esophagus, though the recurrent laryngeal nerve does live between the esophagus and the trachea. And so often the thyroid tumors will go back in there and we have to treat near there. And so this is where someone gets pain when they're swallowing. It might feel like razor blades. I found we have a lot of treatments for that. Carafate is a prescription medication. I consider it like a super Pepto-Bismol. Magic mouthwash is not magic. It's just lidocaine, Benadryl, sometimes steroids, nystatin. It numbs things up. Sometimes use oral steroids to reduce things. Ibuprofen can help, things like that. And then some people get some spasms, and there's actually two trials, one randomized where they taking peppermint candies or peppermint oil actually decrease esophageal spasms. And then really the long-term risk of the esophagitis is causing scarring where you can narrow it up. And so, many times when I'm treating someone with more advanced thyroid cancer, often dedifferentiated or poorly differentiated, there's there's esophageal invasion. So we're treating the esophagus, and those individuals often do get strictures. And so then they become good friends with my GI colleagues because they'll get scoped and they basically do a balloon that dilates and I would say the majority of people get 6 to sometimes as many as a dozen of those, and then it's fine. So it's not a long-term thing where they need a feeding tube or something that because they can't eat. And actually most thyroid people, I would say I can think of maybe 1 or 2 thyroid individuals I've treated where I've needed a feeding tube in the treatment. Mucositis is sort of throat pain, mouth pain. That's just soreness in there. Certainly, if you're getting chemo, this happens even if you're not treating the mouth up higher. And again, the pain stuff resolves within a month of completion of radiation. And we have a lot of interventions here. Baking soda, salt mouth rinse, glutamine actually has been shown to reduce in animal models and human studies the soreness in the mouth. And we used ibuprofen, gabapentin's a prescription non-narcotic medication for neuropathic pain, steroid bursts, that's dexamethasone. Rarely need narcotics these days, it seems like, to help people with their mouth or throat pain. Sometimes people get thrush, that's a yeast infection in the mouth. Fluconazole is a drug we use for that. The fatigue, around 3 weeks into treatment. Again, this is all things sort of build up as the treatment goes on. This is for conventionally fractionated radiation, I should highlight. That's just that people feel tired. Not that they can't get out of bed in the morning or do their activities, but just go to bed early, take a nap in the afternoon, sleep in. And the best medicine for this is actually being active. And at the university, we have this Be Fit, Be Well program. There's a gym, you get a free personal trainer, you pay a small fee, you get access. And folks love that. They wear the t-shirts around and everything. The sunburn, or radiation burn to be more precise, we call that dermatitis. And so that's that the neck skin will get red, irritated, itchy, tender, painful, peel. We don't see blistering. That just does not happen. But you can get ulcers, sores, rarely these days. And we have a lot of good creams, lotions, dressings, all sorts of stuff. We use a steroid cream commonly because there's good randomized evidence that adds benefit. And with our more modern radiation techniques, we see less of that dermatitis. And then dry mouth, that during the radiation with the inflammation, you get more mucus that you might be coughing up and things like that. Mucinex works really well. I tell people to get a humidifier, put it right by their bed, hydrate. And then so the Mucinex is guaifenesin. And then if someone's really having a lot of secretions, we sometimes use the scopolamine patch, like for motion sickness, that actually dries you up. Glycopyrrolate's liquid or pill that does the same thing. Weight loss, if it hurts, you can't swallow, things like that, you're gonna lose. So we always have a nutritionist. I have one dedicated just for head and neck at both hospitals I work at in UC Health that see individuals who are going through radiation. And here, since I came here, they used to put in feeding tubes prophylactically in anyone getting radiation to the head and neck. I stopped that. We do not do that anymore. It's a painful procedure. We can do them quickly if needed, but it's just better for people to keep swallowing. It increases functions over the long term. But if someone's losing weight or they absolutely request it, then certainly we do it. And the xerostomia, that's dry mouth. And again, that's if we're treating lymph nodes when we're treating the thyroid, so treating higher up. And that can take 2 to 3 years to recover. There are some prescription medications, things like that. Now with modern radiation techniques, usually year out, if I've treated lymph nodes up near the salivary glands, people don't really report a dry mouth. We have a whole questionnaire that you get that asks that kind of thing. And most of the time it's like, oh yes, if I go for a run or I'm out doing this or that, I'll feel dry. But other than that, and it's Colorado. I know many of you are not here, but it's very dry here, particularly as it cools off. And then taste changes. This would just be if you're getting chemo or we're treating up near the mouth. And, there's really almost everyone gets it to some degree, but it really varies in its presentation. Sometimes it's that things taste metallic or they taste like they're in the next room or they taste bad. And, again, nutritionist helps with that. So that was sort of side effects. The one additional thing I will say about the side effects is that, that was mainly for the 6 weeks, 7 weeks of radiation. Now, when we do the shorter treatments, the 1, the 5, well, in the neck, 5 or 10 sometimes, the side effects often don't show up during the treatment, interestingly enough. Sometimes the fatigue does, but it's usually a week or 2 later, you get those side effects, but often they're a shorter course. Of the side effects, which again, I alluded to, like reirradiation. I like that better because the side effects seem to be more limited. And again, we actually are, speaking of future directions, I mentioned what we're trying to do at the University of Colorado with the shorter courses of radiation for thyroid cancer, but we're trying to do that in head and neck cancers in general, try to move to shorter courses of radiation. And so that's something that's being advanced more. I think I have another slide here. Yeah, so the shorter courses, and then combining radiation with other targeted agents as more and more get developed. There's some caveats there that, that can increase side effects and things like that. And then, be more aggressive, what we call oligometastatic thyroid cancer. And the problem there is, for most differentiated oligometastatic thyroid cancer, you might not need to treat them for a while. So it's really, when do you decide to do that? And then questions. Thank you. And thanks for the invite. And it's really an honor to talk to everyone here in person and online.
We do have a question on Zoom. Is there a way to minimize tongue exposure to minimize dysphagia? I don't know how to pronounce
Oh
that
yeah,
word.
that's dysgeusia. That is taste loss. So yes, so it's a great question. We've tried to do zinc treatments, thinking that might help. But again, it sort of depends on where you're treating. And if someone's getting systemic therapy, that often affects taste, and there's really nothing to do about that. But if you're radiating in the mouth, a number of things we try to do is we consider the tongue what we call an organ at risk, which is our terminology for something you should minimize radiation dose to. And so in that case, we try to minimize dose to. But I can tell you, if you do your best job to try to avoid dose, it's just every individual is different. And so I put mouthpieces in, try to push it out. I work with a prosthodontist here in town. He'll make these really elegant mouthpieces to push things out of the way, and people still get taste loss to a degree. That being said, it does tend to recover, and it is dose dependent. So the less dose you're getting, and certainly those shorter courses of radiation, I feel like have less dysgeusia, taste loss.
There is a, I'm sorry. Okay. There is a lifetime limitation in the amount of radiation that you can be exposed to. Before you start radiation with somebody, do you look at the history?
Yeah, so that's a great question. There's a caveat to that too, but yeah, there's a lifetime for someone's body to experience. And that can be different for different individuals, and it's different for, like, I have a lifetime exposure risk because of what I do, because I might be exposed to radiation and limits there. But for someone who's coming in and getting therapeutic radiation, really what we look at is like where they've been radiated before. And so someone that's had radiation to the same area where we might be treating again, then there's a lot of counseling that goes on about that, because all those side effects I just described, particularly the scarring, we call that fibrosis, and particularly some of the arteries, carotid artery can be susceptible when you re-radiate. Those are conversations that we have and part of the consent process. But let's say, you're treating someone at different sites in their body, lung, arm, brain, things like that. That, in that case, we worry less. And I'm actually, I'm unaware of any reports of anyone sort of having issues when there's multiple sites treated. But unfortunately, I don't know if we have a lot of follow-up on that once someone's been treated at multiple. But I myself personally have treated someone with sarcoma 27 times to different sites on the body. And it's all often with that high dose radiation, very localized. But mainly when we worry about re-radiation, it's like if you're treating the same spot over.
You did not mention drugs used as radiation sensitizing agents. Is that still a thing, or is it not used in head and neck? Or
Yeah. So that trial, the phase 2 trial for the dedifferentiated or poorly differentiated thyroid cancer done at MSK, I had a brief slide on that. The doxorubicin, it's one of the most potent radiosensitizing chemotherapies. And then when we do treat poorly differentiated, we often use carboplatin and paclitaxel. That's a regimen of chemotherapy agents that do sensitize the cancer cells against the radiation. And I do find a lot of success when we treat someone that's unresectable, that's poorly differentiated, and when we add in the chemo. Now, a lot of targeted agents are coming on board for thyroid cancer. The BRAF MEK inhibitors, lenvatinib, some people may know about. So these are tyrosine kinase inhibitors. They sometimes target blood vessel formation, angiogenesis. Those we often hold during radiation because of worry about increased toxicity, bleeding risk. So I often hold them 3 to 5 days on either end of the radiation regimen. That being said, I have done concurrent radiation with BRAF MEK inhibitors without increased side effects doing that. And then immunotherapy is a newer one too. It's being more used in more aggressive forms of thyroid cancer. That, there's a lot of side effects potentially from immunotherapy, but from combining with radiation, there's both some potential positive synergistic side effects where you might be priming the body's immune system to the cancer to help attack it. And then also there's more vitiligo, which is the lightening of the skin, potential increased risk of treating the lung of pneumonitis, inflammation of the lung when you use immunotherapy. But no, these are all things that we try. No, so that goes back to the radiation oncologist. It's really where I have to put on my oncologist hat a lot to know what all these other agents are. And one of the best advice that I had a attending physician who would pimp the heck out of you and make you memorize clinical trials. And he always said, it's because someday you're going to be a radiation oncologist and the medical oncologist will come to you and say, like, I just got a fellowship. I don't know what I'm supposed to give here and how much. And I was like, that's never going to happen, but it's happened. so it's always good to know. And it's good for patient care because I should know what someone's on. And this goes beyond even the targeted agents or drugs or things like that. It goes to prescription medications and also any supplementary things someone's taking that we need to go through and make sure it won't harm the efficacy of the radiation or cause increased side effects or things like that. So, I mean, it's always, your radiation oncologist will always be looking at those things. So in your oncologist in general, and for people that are getting systemic therapy, we actually have an oncology pharmacist that will go over everything too, as well.
This is the last question. Jumping back to the lifetime limit of radiation, do we know what that number is?
No, in the prolonged setting, no. There's actually some pretty good data, and I'm not as facile with it as some others might be, that, it's from Hiroshima and things like that, where actually do have some data on, because they know distance from the blast and exposure risks. But it's the human body is an amazing thing on how it can heal and how everyone's affected differently. And the same with Chernobyl too, because there's a lot of exposure through the air there, and they've done calculations on stuff. And so it's the things are, we know the total dose is related to risk of secondary cancers that people are often worried about. But not for most people in this room or online. When we treat the head and neck, we were about the thyroid because we cause hypothyroidism, low thyroid function. About a third of people that get radiation, and they've tried to spare the thyroid, calculate dose, only treat one side of the head and neck. Doesn't matter. Like, people still develop low thyroid function. So the body's interaction with radiation is very, so we don't know the total exposure, because some people have gotten a lot of radiation, had no issues. And some people get a little radiation, do have issues. And so I think there's all sorts of other things going on in the body that we just don't fully understand yet.
Thank you very much for your time, Doctor.
Thank you.
And thank you for all the great questions.
Yeah, thank you for all the questions. Thanks.